So now we're on to lower respiratory problems. Acute bronchitis is defined as inflammation of bronchi in the lower respiratory tract. Most cases are viral, and a way that we can tell if it's bacterial is sometimes colored sputum means that it's bacterial. Not all the time, but that's just a quick way to do that. The thing with bronchitis that's different from other pulmonary lower respiratory disorders is that the chest x-ray will be clear with bronchitis, since there is no inflammation or any processes going on in the lungs themselves. Lung sounds can be a little coarse, however. You might have some bronchi, or you might have bronchial breath sounds where they shouldn't be. That really depends on whether it's viral, bacterial, and obviously how bad of a case of bronchitis it is. Treatment is mainly supportive. Obviously, unless it's bacterial, then antibiotics will be prescribed. But cough suppressants, bronchodilators, and inhaled corticosteroids to help decrease the inflammation are mainly used. Pertussis is a highly contagious respiratory infection caused by gram-negative bacillus. When patients are in the hospital, they are on droplet precautions, meaning they need to wear a mask. Pertussis is also known as the whooping cough. We are vaccinated as children to this, and it's recommended that adults get vaccinated again due to the increase in incidence and the whole thing around people not vaccinating. It affects very young children because our Tdap series that we get as infants is a series of 5 shots starting at 2 months of age. So infants are not fully vaccinated until, I believe, 18 months or so. So that's why they are most at risk, because they're not fully vaccinated. Symptoms begin as a mild upper respiratory infection with cough, runny nose, low-grade fever, and then it progresses to coughing, especially at night. And then upon inspiration, you get this really loud whooping sound, and that's because air is passing through the swollen part of the throat that's making that whooping sound. Uncontrollable violent coughing can be present, which is very distressing to young children. Luckily, we have antibiotics that can treat pertussis. Unfortunately, you need 5 days of antibiotics before you're considered contagious, unlike the normal 24 hours. Over-the-counter medications aren't really suggested because they really don't help that much. Antibiotics are what treats this. And then we move on to pneumonia. So we see a lot of pneumonias in the hospital setting. So there are 3 categories of pneumonia. There's community-acquired pneumonia, medical care-associated pneumonia, and then aspiration pneumonia. We get the community-acquired pneumonia when we haven't been in a long-term care facility or hospitalized within 14 days. And then our medical care-associated pneumonia encompasses like the healthcare-acquired pneumonia, our VAPS, pneumonias that have occurred since in the hospital where patients got that in the hospital. And then our aspiration pneumonia, where mouth or stomach contents enters the lungs, and then an inflammatory response is initiated, and the alveoli are flooded with just as much bacteria and neutrophils to fight the infection, along with fluid. Some risk factors for pneumonia include decreased immune response, advanced age, surgery, altered level of consciousness, smoking, intubation, right, because of the VAP, and patients that are immunosuppressed, such as those receiving chemo or radiation, long-term care facilities, and malnutrition are all risk factors. Pneumonia can either be viral, bacterial, fungal, chemicals. Certain chemical exposures can cause a pneumonia or a parasitic infection. So mainly it's just, a lot of times we see bacterial infections. The problem is that with recurrent pneumonias, that our bacteria get resistant, and it's much harder to treat those types of pneumonias, such as in the medical care associated pneumonias. We see a lot of resistant bugs more so. So I like this little diagram of pneumonia, it has a lot of good information on it. So pneumonia obstructs the bronchioles, the smaller airways, which results in decreased gas exchange and increased crap within the alveoli. So you can see that that guy is holding some nice little bugs in his specimen container. It's important to obtain a sputum sample prior to initiating on antibiotics. However, in reality, we do not hold off on antibiotics prior to getting the sputum culture. We can initiate a cough by having patients inhale hypertonic saline, but it's not very common. How they do antibiotics is there are certain bugs that are most likely in community-acquired pneumonia. So they'll be placed on certain particular antibiotics where the bacteria is mostly present with community-acquired pneumonia. And then we see other bugs in hospital settings. So they'll choose antibiotics where it's most likely those bugs, if that makes sense. So some of the symptoms we can see: cough, fever, chills, tachycardia, tachypnea, pleural pain, which is pain on one side. It's not uncommon for pneumonia to be one-sided. Generally it is. So they may have pain on that side of their lung. Breath sounds, that they can be all over the place. They can be diminished. Patients can have coarse crackles, rhonchi. They can have fine crackles, wheezes. It really depends on what's going on in the lungs and whether or not it's bacterial, it's fungal, viral, etc. Older people sometimes can present a little bit differently, maybe just with confusion from hypoxia, because remember, as we age, we don't have the compensatory mechanisms and the regulatory mechanisms to respond to hypoxia and hypercarbia as we do when we are younger. You'll also see the doctor's orders: sputum culture, chest x-ray, and ABGs. Again, a sputum culture is always ordered, and we would like to get one, but sometimes it's not really, we don't hold off antibiotics if we can't get one in this circumstance. However, in our little NCLEX world, we always want to, get every sample prior to antibiotic use, but in the real world, we don't delay therapy just to get a sputum culture. There are several complications of pneumonia that are presented in this chart here. So pleurisy is just inflammation of the pleura, and this is presented as a pleural friction rub, which we have heard about. Pleural effusions, which is extra fluid in the pleural space. Bacteremia or sepsis from that bacteria getting into the bloodstream from the alveoli. Lung abscesses, which is a loculated area of basically junk in a certain portion of the lung. Pericarditis can happen from the infection. Empyema, which is pus in the pleural space. Other complications include a pneumothorax and ARDS or ARDS, which is a very advanced form of pulmonary disease, and we do a chapter on that as well. Some diagnostics that we expect ordered for pneumonia is a chest x-ray to see where the pneumonia is and the extent of the pneumonia. History and physical, because that could help us determine whether it's community-acquired, medical care associated, or aspiration pneumonia. A sputum culture, although we do not delay treatment if we cannot get a sputum culture. And then labs such as a CBC to see a white count, and then a CRP and a procalcitonin. So our CRP is our inflammatory marker, and then procalcitonin can help us to determine if there's a bacterial infection present. For bacterial pneumonia, antibiotics are the medication of choice. So educating patients to take all courses of antibiotics. It's not uncommon for patients to start out on an IV form of antibiotics and then switch to PO as soon as the patient is able to, especially in the hospital setting. Nutrition or hydration is very important. Small, frequent, high-calorie foods. Health promotion, including to stop smoking if patients smoke, obtain the pneumonia vaccine for those who are at high risk, and identify patients that are at high risk, such as those on a ventilator or those that have aspiration precautions to try to prevent. Coughing and deep breathing, so a SMIM or an incentive spirometer is great for these patients to help them cough and deep breathe. Oxygen is also almost always ordered for patients with pneumonia, right? Because if we have a bunch of bacteria and crap in our alveoli, then those alveoli cannot participate in gas exchange. So I really don't have the surface area for gas exchange as I normally would. Follow-up chest x-ray is generally done 1 month after treatment, maybe even 6 weeks if it's extended, but we just want to make sure that that pneumonia is not lingering because sometimes that can happen. So tuberculosis is caused by a specific bacteria called Mycobacterium tuberculosis. It is an airborne bacteria, so that means negative pressure rooms with an N95 mask. It still remains the leading cause of death in patients with HIV. And generally, there needs to be prolonged exposure before somebody is actually infected. So prolonged exposure via breathing, talking, singing, sneezing, coughing. You cannot contract tuberculosis by sharing utensils or by close physical contact as long as the patient isn't doing any of those things that I just mentioned. So what happens is when the bacteria enters our lungs, our bodies close in the bacteria, which is called a granuloma, which we see on a chest x-ray. And this granuloma is formed to avoid the spread of the infection. So our bodies help a brother out and they kind of loculate this area. They like wall off this area of tuberculosis bacterium. This granuloma can be seen on chest x-ray. So this bacteria can either lay dormant, aka latent phase infection, or it can become active right away. In a latent infection, it can lay dormant and decide to come out at another time when somebody is immunocompromised. So a primary infection is when patients actually have those symptoms. So the inflammatory response is initiated and patients will be symptomatic with the symptoms that are displayed below. Latent phase is what happens in healthier individuals. So that bacteria is, granuloma is formed, and that bacteria lays dormant and waits for you to become immunocompromised and waits for the perfect opportunity to infect your body. Patients most at risk for contracting tuberculosis are the poor, homeless, inner city residents, those that are living or working in institutions such as prisons, shelters, hospitals, IV drug users, and those on immunosuppressive therapies. Unfortunately, symptoms of TB don't develop until 2 to 3 weeks after exposure. So patients in that active phase can spread it to somebody else. So the primary infection is also called active infection. They could be spreading it to somebody else and the symptoms aren't there yet. Only those with an active infection can pass the bacteria on. So someone with latent phase tuberculosis is not contagious. So how do we differentiate between active and latent phase if there's 2 to 3 weeks between those time periods? Well, latent phase is only diagnosed when active TB is ruled out. So these diagnostics try to rule out active TB. So the TB skin test is a screening for tuberculosis. It's an induration that is looked over, we have to look at it 48 to 72 hours later. So this means that the person has been exposed to tuberculosis and has developed antibodies to this. We now have a 2-step process for the TB skin test. That's to ensure that future results remain negative or are definitely positive. So it's to help rule out some of those false negatives that we can get or false positives. So the blood test or the interferon Y assays are a blood test, and they are responsible for detecting the mycobacterial agents. So the cost is higher, but there is less chance of a false negative with the blood test. So again, this does not diagnose TB. This just helps rule out exposure. Chest x-ray is also an aid in the diagnostics of tuberculosis. So there's not a telltale sign that's seen on a chest x-ray for TB. We might be able to see those granulomas, but it's really used to help rule out active TB. The thing that really diagnoses tuberculosis is a sputum smear. That sputum smear is called an AFB smear, acid-fast bacillus testing, and that's the specific test to determine whether or not tuberculosis is present in the sputum. So with this, 3 different sputum specimens are obtained on different days and examined for the bacteria. Unfortunately, usually these sputum smears need to be sent out, and the cultures can take up to 8 weeks to grow. So in the meantime, it's really important to tell patients to use some cough etiquette and dispose of used tissues in a paper bag. Make sure that they do proper hand washing, minimize prolonged visitation, and they're encouraged to avoid crowds because contracting tuberculosis really depends on the amount of exposure that you have. So the least you can provide exposure to somebody, the better off. So medications for tuberculosis. Those consist of rifampin, INH, pyrazinamide, and ethambutol. So those are the 4 most common medications that are used to treat TB. Patients that have active TB and are on medications to treat their active TB are considered infectious for the first 2 weeks of treatment. So for active TB, it's not uncommon for patients to be on these 4 medications, possibly all at once. There are other medications on the market available to individuals who develop reactions to these medications or maybe cannot tolerate them because of liver disease, which is a very big complication of these. Those who are pregnant, HIV positive, such things like that. So baseline LFTs are needed prior to treatment, and then sometimes monthly tests are also obtained for those at risk for liver toxicity. And then obviously avoiding alcohol because we don't want any more damage to the liver. Unfortunately, there's a lot of risk for non-adherence and non-compliance to this drug therapy. Usually drug therapy can be upwards of 9 to 12 months. So if you think about our at-risk population, those who are homeless and poor and IV drug abusers, the probability of them going to the clinic to get their prescriptions refilled for that long and possibly having to pay for them is not very high. So we really want to make sure that we follow compliance, and that's where DOT therapy comes in. DOT therapy is direct observation therapy. These are nurses and other healthcare personnel that go around and basically track people down to give them their medication. Because if we have a lapse in antibiotic use, which these are antibiotics, then we can have multi-drug resistant bacteria, which is actually present with tuberculosis. So we want to try to not have that. Treatment for the latent phase TB is possibly either INH is a common one for about 6 to 9 months, so they'll just be on 1 medication. That's for latent phase TB. Because with latent phase TB, even though they're not contagious and they don't have symptoms, we don't want that bacteria to become active at a later part of their life. So we covered that the main side effect for these medications is liver toxicity. So we're looking for jaundice, yellowing of the eyes, and tracking their LFTs, their liver function tests. So specifically for rifampin, we want to educate patients that their body fluids are going to be like a red-orange. So their urine, sometimes their contact lenses can be stained. INH, people on INH need to take an extra supplement of vitamin B6 to prevent against peripheral neuropathies. So INH needs to take vitamin B6. And then ethambutol, the big thing with that is ocular toxicity. And that sums up the side effects that I really want you to be aware of. So there is a vaccine that's available. It's called the BCG vaccine. It's available to those in third world countries or those really at high risk for tuberculosis. For example, sometimes if you're in the military and you're visiting an area with a high TB prevalence, then you can get the vaccine. But generally, it's not one of our usual vaccines that we get. So we are required to notify public health if tuberculosis is a positive diagnosis, and this is just to initiate that DOT therapy to ensure compliance with medications. So even though patients are contagious for 2 weeks into their antibiotic therapy, we don't keep them in the hospital for 2 weeks. We do send them out with specific instructions. No, they don't need to wear a mask. They can if they want to, but it's airborne. So they need to avoid large crowds. There actually used to be a camp up in Lake Saranac that was a tuberculosis camp. So patients from the city would be sent up to Saranac Lake, and they would be in these like homes. It was like a little camp until they felt better. And this was because, you know, the less that you have exposure to tuberculosis, the less likely you are of spreading that. So part of the treatment, obviously it's not around anymore, was to just not be enclosed in small spaces. So not sleeping with anybody in bed, avoiding large crowds, again, as best we can. So a lung abscess is caused by necrosis of the lung tissue or from poor oral hygiene that can enter the lungs and then cause an infection in the lungs. So necrosis of lung tissue, and it forms a cavity filled with this purulent material. Usually these abscesses occur slowly over time, and a chest x-ray is really the only diagnostic tool that's needed to diagnose this. Some of the symptoms: foul smelling or tasting sputum, fever, chills, shortness of breath, weight loss. People will feel really crappy if they have a lung abscess. For this, IV antibiotics are indicated for a lung abscess, and we really want to make sure as nurses that we do not perform any chest physiotherapy or postural drainage. So this is no percussion, no vibration, because we don't want to break open that abscess that's in the lung and have that infection spread. So we'll also cover some chest trauma and thoracic injuries. We're going to kind of graze the surface right now because we revisit these when we get into emergency medicine. So when we say pneumothorax, there's actually several different types of pneumothoraxes that can happen. So somebody can just have a pneumothorax, which just means a collapsed lung. And then sometimes there's other different ways of describing those pneumos. So a spontaneous pneumothorax usually occurs from rupture of small blebs. Blebs occur in healthy young people, usually who are very tall and thin. And then these blebs rupture and cause air to enter into the pleural space, and that causes a pneumo. Generally, it's treated with a chest tube, and then the patient, it's resolved from there. Iatrogenic is laceration or puncture during a medical procedure. For example, placement of a central line or a thoracentesis, barotrauma from excessive ventilation. So a lot of things, we need to be careful of so we don't create pneumos as healthcare providers. Traumatic can either be penetrating or non-penetrating. If there is an object sticking out of the chest, we want to make sure that we do not remove it because it can further collapse that lung. And then there's a tension pneumothorax. So a tension pneumothorax is a medical emergency. It is when there's an increased accumulation of air that results in compression of the lung on the affected side. So if I have air entering in from my left side, it's going to be my left lung that, deflates, right? That's my affected side. It can also cause pressure against the heart because the mediastinum shifts. So we'll see some tracheal deviation. And it can cause decreased venous return due to the buildup of pressure in the thoracic cavity. A hemothorax is blood in the pleural space that's usually from trauma. And then a chylothorax is milky white fluid. It's lymphatic fluid that's in the pleural space, and it's caused from a rupture of a thoracic duct. It can also be caused during thoracic surgeries or open heart surgeries such as CABGs. So those are just some of the different types of pneumos and what they mean. So for a pneumothorax, depends on the size. Nothing might be done except monitoring if the patient is stable enough, or the pleural space can be drained via a thoracentesis. And sometimes a chest tube is placed to allow drainage of that fluid for a prolonged period of time if need be, especially if patients have had surgery. Attention pneumo is the medical emergency. It requires immediate needle decompression where they put a needle into the pleural space to allow that air to come out. And it sounds like a soda can opening when that needle is placed and the air escapes from the pleural space. And then a chest tube is placed after attention pneumo to make sure that that lung reinflates appropriately. So it really depends on the type of the pneumothorax and how the patient's responding. Pleural chest occurs from the fracture of several consecutive ribs in 2 or more separate places, or fracture of the sternum. So it causes paradoxical movement of the chest wall. So during inspiration, the affected lung is sucked in, and then during exhalation, the affected lung bulges out. So it creates a very asynchronous movement of the chest wall, and it allows for the patient to inadequately ventilate. Many times patients do need mechanical ventilation, depending on the degree of flail chest that they have. Pain control and pulmonary toileting are very important for these patients. So chest tubes are in place. They're used to re-expand the lung. There's no really set time frame for when chest tubes are expected to be in place. It really depends on the patient and the reason for the chest tube to begin with. We confirm placement of the chest tube with chest x-ray, and patients also have follow-up chest x-rays to determine if that lung is being reinflated. Pain medication is extremely important. It's painful to have a tube sticking between your ribs. There's 2 types of chest tubes. There's the Heimlich chest drain, which is for patients who have chronic pleural effusions. It's actually just this little pouch that has a one-way valve that patients can carry around with them. And then the pleural drainage is what we see in the hospital with that big, box-looking thing that we'll see on the next slide. So this is a picture of a chest tube. So this is a chest tube atrium is what it's called. So you'll notice that in this picture, there are 3 different chambers. So the first and most obvious is the collection chamber, and this is where all those numbers are. So you'll see anywhere from 0 to 2000. This is the collection chamber. So it either collects air, fluid, purulent matter, whatever. The second chamber is where you see the blue water. It's at the bottom left. This is the water seal chamber. So that way air escaping from the lung goes into the collection chamber and kind of traps itself into that water seal. And then atmospheric air cannot get back into the lung because of this water seal. So it acts as literally a seal between the lung and the environment. So this water seal chamber, in it, you will see fluctuations. So you'll actually see tidling. That blue water will it'll tidle. It will sway back and forth with respirations, and this is normal. What's not normal is in this water seal chamber, we might see bubbling. And bubbling in the water seal chamber means that there is some sort of air leak, which means that it's not a very tight connection, either from the chest tube or because you have a foreign object sticking out of your chest. So sometimes that's why you can have an air leak. So is it detrimental in an emergency? No, it's just something that needs to be monitored. So if I have more bubbling or more vigorous bubbling, that would indicate a larger leak. So the size of the bubbles that you see indicates the size of the air leak. So bubbling in the water seal chamber indicates an air leak and is not something that we want to see. The third chamber is the suction chamber, and that is in the dark blue. You'll see that little red knob. This is dry suction. So the provider will order a specific amount of pressure to, like negative pressure, to pull fluid or air off of the lung. So this is how this is done. So that dial literally just dials in, and then you would hook the chest tube up to wall suction and turn the wall suction on. There's a little orange balloon that inflates in the window next to that red dial, and that would indicate that the suction is turned up high enough. We want to make sure that we never have any kinks in the chest tube tubing. The chest tube atrium needs to be below the level of the chest, so it should be either hanging on the bed rail or taped on the floor. If we ever kick over a chest tube atrium, and Lord knows I can't even count how many chest tube atriums I kicked over, well, probably like a handful, maybe like 5 or less. But it really stinks because not only are you you're breaking that water seal, but you're also mixing all of that content in the collection chamber, and then you're unable to really measure the output. So long story short, you have to get a whole new collection chamber, like a whole new chest atrium, to change out. Do you need to call the provider if you kicked it over and stood it right back up? No. You just make sure that the patient didn't have any respiratory compromise because of that, which generally they don't. So when somebody has a pleural effusion, it's not a disease itself, but an indication of disease. So for instance, the most common causes are heart failure, liver cirrhosis, open heart surgery, pneumonia, inflammatory disease. So pleural effusions happen secondary to some underlying disease. It's an abnormal collection of fluid between the visceral and pleural layers of the lung. And again, depending on whether the pleural effusion is causing respiratory distress or depending on how big it is, depends on the symptoms and what interventions are done. So symptoms are generally include dyspnea, cough, and localized chest pain. So our PEs are pulmonary emboli or embolisms. So it's blockage of the pulmonary arteries by a thrombus. It can be fat or an air emboli as well. Lower lobes are most commonly affected, and most can be linked to a DVT that happened in the legs, especially the upper legs. Treatment consists of anticoagulants. The risk factors are outlined there for you. Let's see some of the symptoms. Dyspnea is the most common symptom, and then other symptoms could be tachypnea, cough, chest pain, blood-tinged sputum or hemoptysis, tachycardia, fever, changes in mental status related to hypoxemia. If somebody has a massive PE, it can cause death pretty rapidly. So patients can deteriorate very quickly. So complications of a PE consist of pulmonary infarction, which is death of the lung tissue, which happens with an occlusion of a decent-sized artery. And then pulmonary hypertension can occur as well, which eventually results in right ventricular hypertrophy, and right ventricular hypertrophy can therefore lead to heart failure. So some of our diagnostics are the D-dimer. So this lab test shows the amount of cross-linked fibrin fragments. So these fragments are the result of clot degradation and are rarely found in healthy individuals. So a D-dimer is one of the tests that we look for PEs. CTA of the chest, we use IV contrast to view the blood vessels. A VQ scan is a ventilation perfusion scan. So there are two components to this. This is really only done for PEs. There's radioactive isotope that's administered via injection, and then another one that's administered via inhalation. So patients need to be cooperative in order to have a VQ scan. It's not appropriate for a intubated patient, unfortunately. Pulmonary angiography is the best, but it's also the most expensive and invasive. So these are really not done. Surgery is the last resort for a pulmonary embolism. So treatment has to deal with prevention. So early mobilization, SCDs, anticoagulation therapy. Sometimes thrombolytic agents are used if the patients are hemodynamically unstable. But again, that's kind of last resort. Pulmonary embolectomies have a very high mortality rate, so those aren't used, which is why surgery is kind of the last resort for these patients. Patients who are at risk for PEs, we can place an IVC filter, and that's to prevent clots from traveling into the lungs. So it's a little filter that kind of catches the clots before it gets into the lungs. So pulmonary hypertension can be a primary disease, which means people are born with it, or it can be a secondary disease, such as something like pulmonary fibrosis, something that's acquired over time. Most of the symptoms manifest as shortness of breath and fatigue, and over time it progresses to heart failure, mainly right-sided heart failure, because the right ventricle is having to pump extra hard to get into the pulmonary vasculature that is hypertensive. So it's kind of like left ventricular afterload, except we're talking about the right side of the heart. Patients can also have exertional chest pain and dizziness. Patients will mainly require oxygen and some medications to help dilate their pulmonary arteries, such as calcium channel blockers, endothelin receptor antagonists, and vasodilators. Especially if it's a primary disease, patients may be on a lung transplant list. Cor pulmonale is the term that is given to right-sided heart failure caused by an underlying respiratory disorder. So in the slide that we were just talking about, if I had pulmonary hypertension and now I have right-sided heart failure due to that underlying pulmonary hypertension, it would be defined as cor pulmonale. So really treating cor pulmonale is treating the underlying respiratory condition, such as COPD, and also treating the heart failure. So you kind of had this dual diagnosis that you're trying to treat at the same time, hence the treatment that you can see below. All right, and that sums up these slides on lower respiratory.